Hello and welcome to tonight's Rural Doctors broadcast. I'm Gerry Gannon. Thanks for your company. In our programme tonight, we revisit a regular topic for our programmes, women's health. There's a constant stream of new products for things like period control and contraception, and it can be hard to keep up with all the options. So tonight, we'll do our best to give you an update. Later in the programme, we'll speak with Dr Terry Patsakis about recent changes to chlamydia screening and reporting and the information within the recently released Partner Notification for Chlamydia Resource Folder for GPs. We'll also visit with the WA Perinatal Mental Health Unit about depression and other mental health issues that can be associated with pregnancy. But first, let's join Dr Olga Ward as she talks with gynaecologist Dr Robyn Leake and GP Dr Alison Creagh from Family Planning WA.
Welcome to the program, Robyn and Alison.
Thank you very much.
Thank you.
Could we start by talking about bleeding being one of the most common symptoms that women present with? And I think menorrhagia is sometimes a little more common even than GPs realise. But how do you define somebody as suffering from menorrhagia?
I agree. I think it is a very common symptom, and women put up with an amazing amount of bleeding before they seek attention. I think generally if a woman complains that her bleeding is unacceptably heavy, she's probably correct. And the other giveaway is women who are iron deficient. I see a lot of ladies who've had a diagnosis of iron deficiency, have been investigated with a colonoscopy and an endoscopy, but the periods remain heavy and need to be addressed. Would you agree?
Yeah, we see it a lot. Yeah.
I must admit, I see patients and I'll ask them about their periods and they're bleeding full on for 7 days and they need a pad and a tampon, and I think, well, isn't that unacceptable? And they say, oh no, it's always been like that.
Yep.
And so it has never occurred to them to be abnormal. So I guess you just always need to ask, yeah? And how often do you see patients actually becoming quite iron deficient?
Well, in my practice, a lot.
Yeah, and certainly FPWA, a lot.
Yeah. So what are our patients' options if we're going to help them control that sort of bleeding?
Yeah, I suppose for sort of from primary care, we tend to look at, well, how much bleeding and therefore which might be the best option. If it's not too bad, then anti-inflammatories just during the period, tranexamic acid, again, just during the period, and not too many contraindications for that. Alternatively, if they also need contraception, things like the pill, the vaginal ring, which gives them some reduction of the bleeding. Perhaps Implanon if it's not too bad, but you can't really guarantee what would happen with the bleeding there. And certainly consider the progesterone IUD if the bleeding's a fair bit heavier and they feel okay and they don't have any contraindications to an IUD.
And I guess progesterone, you were talking about the Implanon, and I guess the progesterone Depo-Provera would be in that similar kind of scenario, wouldn't it?
Yeah, because Depo would effectively reduce it a fair bit. You just might get a bit of an increase to start with, which would be a bit of an issue.
Are there any specialist tricks that we haven't mentioned there, Robyn?
I think you need to think about pathology, so clinical examination, and there is, I think, a role for ultrasound in a lot of patients in elucidating whether there may be a polyp or fibroids or other pathology. It doesn't mean that you can't do all your basic manoeuvres, but you may be, if there's evidence of pathology, you may be prepared to look at a more surgical option earlier on. And certainly, if there's any hint of abnormal pattern to the bleeding, intermenstrual loss, etc., then excluding pathology is important, I think.
Yeah. So what about doing things like a DNC or a PAPEL, which are often the only two kind of more invasive investigations that you can do in a country practice?
Yep. Certainly, I think a PAPEL's well worth a shot. If you can get a good sample, it has 90% accuracy in terms of excluding pathology. Obviously, PAPEL's not going to snare a polyp for you, which is a bit unfortunate, but certainly if you're if someone's perimenopausal and you're just wanting to exclude hyperplasia, I think it's a very reasonable and pretty simple to perform manoeuvre.
If you do a DNC, does that actually do anything in terms of managing the menorrhagia, or does it just give you a diagnostic sample?
No, it's a diagnostic test, and when we do a DNC, we usually do a hysteroscopy as well. So if there's a polyp, you can do a guided rather than blind biopsy. But certainly it's not therapeutic, and I'm always I think it's important to explain that to patients so that they don't have unrealistic expectations of the manoeuvre.
Yeah.
And if you're trying to exclude pathology and you're doing a PIPL, would you also try and do a transvaginal ultrasound if that was available
Certainly.
locally?
Yes, certainly.
Yeah, that's certainly available in many country centres anyway. Alison, do you insert marinas for bleeding control?
Certainly. And again, as Robyn said, we are careful to exclude pathology first. Quite often people are referred in for a marina, and we actually find that there's something a bit funny about their bleeding, so need to send them away while we investigate. So we usually make sure there's an up-to-date pap smear, make sure they've had some recent swabs, particularly looking for chlamydia, if there's any risk at all, plus the intrauterine pathology. So usually a transvaginal ultrasound and or hysteroscopy and or PIPL sample.
Or a PIPL sample.
Yeah. But once all that's clear, we're really happy to put them in, provided there are no sort of big fibroids that would get in the way or any other contraindications.
Yeah, and I think I quite often will do a D&C just to get a good diagnostic sample and then put the marina in at the same time while they're asleep, which always seems to be a pretty reasonable sort of idea.
I agree.
So how real is the risk of something like DVT in patients who are over 40 and they're using hormonal things to control their bleeding?
I think one needs to evaluate the personal risk factors for the patient, so smoking, premature, family history of premature heart disease, whether they're hypertensive, hyperlipidemic, have diabetes, so basically all the vasculopathy risks. But with the low dose formulation, in the absence of those risk factors, the risk is low.
Yeah, would that stop you putting in a marina or using hormonal contraception?
It certainly wouldn't stop us using any of the progesterone methods. If we were thinking about, say, using the pill in a woman over 40, we'd sort of think again a couple of times. Although really the DVT risk just with age is probably sort of double over 45 the risk as a young woman, whereas other risk factors like obesity and family history and stuff are probably more important. But yeah, you need to exclude all of the cardiovascular risks as well as the DVT risks in a woman over 40 particularly. Yeah.
And I think quite often the patients are, they're aware of their cardiovascular status and they're aware of their risk, but they get so much benefit from the treatment, they're happy to take the risk as long as it's explained. Do you have any particular procedure for documenting all of that, or do you just write down what you've discussed? Thinking in a medico-legal framework.
Yeah, we do have quite a lot of checklists that we use. So, for example, if we're going to, we're actually going to prescribe the pill to someone, we've got a checklist with all of the history that's relevant. So, make sure that we've excluded all the contraindications. We've talked about the risks and the benefits. All of that.
And does family planning make that kind of checklist available to GPs? Like, is that a downloadable off the website type of thing?
It isn't, but that's quite a good idea. I suppose we tend to go through that in our courses, and there's a really good resource on the internet, the medical eligibility criteria on the World Health Organisation website. It really thoroughly goes into contraindications. And there's a really useful, it's a bit fiddly to make it, but there's a really useful contraindication wheel that people can download and make up themselves and just have on their desks. It's really nice if it's laminated so it's sturdy, but you can sort of dial up smoking and age and find out that actually it's a strong contraindication for, say, a combined pill if you're over 35 and smoking more than 15 a day. But it's quite okay to have a progesterone IUD, for example. So it's a really handy little tool.
Well, it does sound like a handy little tool, and we'll locate that for our website.
Yeah.
Robyn, when do you start worrying about perimenopausal or postmenopausal bleeding?
Well, with perimenopausal bleeding, I think you need to try, and it is difficult sometimes on history, to gauge whether someone's actually experiencing true intermenstrual bleeding, in which case the risk of pathology is actually quite high, versus irregular anovulatory cycles, which are of less concern. Any intermenstrual bleeding in the perimenopausal age group warrants investigation, but intermittent heavy periods are often anovulatory and can be dealt with in that vein. Postmenopausal bleeding, that's quite tricky, and I think part of it depends on your index of suspicion for the patient. So if you have a lady with all of the risk factors for endometrial carcinoma, even if she has only had maybe 9 months of amenorrhea, you may be more prone to investigate that lady than another.
And what are those risk factors?
Obesity, diabetes, family history of endometrial carcinoma. Probably family histories of adenocarcinoma generally, so breast, bowel, those family clusters.
Yep.
They're probably the big things that raise my alarm bells.
Mm-hmm.
And a fairly simple investigation is a transvaginal ultrasound, looking at the endometrial thickness.
Yeah.
And if you can, a Papel.
And how much will you miss with that sort of investigation?
With endometrial thickness, very, very little.
Mm-hmm.
But again, I think if you see a patient who you have a strong index of suspicion for, I would do the endometrial sample anyway. If the and I always say to them, if the endometrium's thin on ultrasound and the examination's normal and I'm sending them away, if the bleeding returns, come back or ring me or make contact again.
Could either of you talk about controlling bleeding on Implanon? Perhaps,
Yes.
Alison, you might see an awful lot of that.
We do,
It's one of the biggest complaints that the patients have about Implanon, either in the initial period or, at about 2.5 years when it's starting to run out.
Yeah.
How do you deal with it?
I guess the first thing is really just sort of to listen to what's been happening and see if it sounds like it might be settling down, in which case a little bit of encouragement to persist and see what happens may be useful. If the person's not happy just to persist with it, then provided they are okay to take the pill, that's usually our first option because it seems to be the most easily available effective option. So take it for a couple of months, stop it, get a withdrawal bleed and see what happens after that. If we're lucky, the bleeding will have just settled by itself in the meantime.
And you just use a normal bog standard combined pill for that?
Bog standard monophasic type pill, yep.
Mm-hmm.
Now there's a bit of research which Martha Hickey from King Edward was one of the investigators for, looking at using doxycycline. So we haven't actually started to use that yet, but it's 100 milligrams twice daily for 5 days, just at the beginning of the bleeding, and see what happens.
What does doxycycline do to bleeding?
It's felt that it's not actually an antibiotic property, that it's actually anti-inflammatory at the endometrial level, and somehow or other it seems to settle things down. And I must say, anecdotally, having used it a few times, it does seem to work. But obviously it's not something you wish to continue long term, unless you're in a malaria-prone area. And so it's not... it's something to use intermittently, and often it does buy you a bit of time.
And you would use that in preference to something like Ponstan, which just settles cramps, really, doesn't it, more than bleeding?
Yeah, it's not particularly effective at controlling bleeding. And there's one other which it really isn't accessible to the usual doctor. It's mifepristone, which needs a special TGA application to be able to prescribe. But that just twice a day for 1 day, and then followed by 4 days of a low dose 20 micrograms of oestrogen, apparently is about as effective. But have to go through the TGA to be able to prescribe it. So
at that sort of 2.5 year time, when they start to bleed through, would you just take the Implanon out and put another one in?
Yeah, I think that's where they go. Yeah. It works for depot if you give the injections a bit earlier, so it's worth a go for Implanon.
And quite a lot of our patients want to control or avoid their periods absolutely altogether. Is that a feasible and safe option for them?
Yep. I think it's preferable, especially in women with endometriosis. So I often get young ladies with endometriosis to, if they're using the combined pill as a method of control, to have 3 periods a year. School children who have terrible periods, once every school holidays for a special treat.
I was thinking how to ruin their school holidays.
Right. And Marina's a great option for provoking amenorrhea. They work often very, very well. And there's no harm at all in using that for that.
Alison, same sort of experience?
Yeah. I know overseas sometimes if people want to not have too many periods, people are advised just to take the pill continuously until they start bleeding, then have a withdrawal bleed,
have their week off
for 7 days, and then start back on the pill. And I presume if the bleeding was to continue or seem a bit unusual after that, that they needed to go back to their doctors. So I'm not quite sure how safe that idea is, but we're quite comfortable to suggest 3 or 4 periods a year without...
I suppose that sounds quite reasonable, really. They would tend to spot through at about 4 to 6 months anyway.
Yeah.
Could we just revisit the Mirena? And from the point of view of fertility return, because most of the patients have got in their minds that if they go off the pill it might take a year for their fertility to return. How quickly does it come back after you take the Mirena out?
It depends when in the cycle you take it out. They basically need another episode of ovulation and for the endometrium to build up again, so it could be as little as 2 weeks or 4, but certainly not much longer than that.
And just on the pill, with the low-dose pills that are used these days, we say assume your fertility comes back immediately, stop it rather than waiting for a few months or a year.
Yeah, and I think that's quite a reasonable sort of option, isn't it?
I actively encourage my patients, especially the ladies with polycystic ovarian syndrome and endometriosis, to not delay. Once they go off the pill, that's very likely to be their most fertile time, and to get on with it. Don't wait 12 months. And just actively discourage them from going off it and using some other form of barrier method or similar. Because
while they wait for their fertility to come back.
Wait for it to disappear again, more likely. So,
so that's quite a different approach to the normal woman that you would just say, go off it at 24 and you'll probably be pregnant by 25. Fair enough. Could you have a talk, Alison, about some of the various methods of contraception that are available? And you mentioned the NuvaRing. How acceptable are the patients finding that?
Yeah, interestingly, I thought it would be really popular. People would love it because it's so easy. But in fact, a lot of people really seem to be turned off by the vaginal route. I think there are lots of advantages in that it's a nice low dose of hormones. People don't tend to get the same level of side effects that they get with the combined pill. They don't need to remember to take it every day, which is the main problem with the pill, because most people forget a few pills per month. So it doesn't work quite so well. And it's really easy. You've just got to remember to put it in once a month and take it out once a month on the right day.
Can they actually achieve amenorrhea with a NuvaRing? Like if they take it out at week 4 on the dot and put another one straight in?
Yeah, similarly to the pill, the breakthrough bleeding rates are slightly less than the pill overall. And like the pill, you can have 3 or 4 periods a year if you want, for most women. There are a few women, both with the pill and the ring, who can't manage to skip periods successfully, but most people can just use the hormones continuously for 3 or 4 months. Yeah.
When you're trying to find the right pill, how do you select the right woman for the right pill?
It's always a guessing game. Most people are fine if you just start them with the basic low-cost PBS monophasic, easy-to-take pills. So I won't mention all the brand names, but the ones with levonorgestrel and norethisterone in them. And then we usually just adjust if the woman has problems. So, for example, if she finds her acne isn't well enough controlled, or her periods aren't well enough controlled, or she gets a bit of breakthrough bleeding with one pill, then we just sort of fiddle with the doses, and sometimes we need to go to the more expensive ones.
Yeah. So start cheap and cheerful and then fiddle from there. Robyn, do you have any specific indications where you would think that pill definitely for that condition or that type of person?
No, I agree. I start cheap and cheerful and only change if necessary. The other thing that I see quite commonly is women referred who've begun to have breakthrough bleeding from being on the pill, and they say, but I've been on the same pill for years and only just started to bleed. And the answer is it's not actually the pill. They've taken the pill for such a long time that their endometrium's become quite thin. Doesn't matter what brand they're on, that's the basic problem. And so and often they've had an ultrasound by the time they've got to me, and I say, I bet your endometrium was thin. Flick it open and say, look, 3 millimetres. So they believe you. And then the options then are to take a break from the pill entirely and allow the natural cycles to thicken the endometrium up again, being aware that they will be at risk of pregnancy, of course, or put them on a higher oestrogen dosage. Or occasionally I've used a little bit of extra oestrogen as an add-back therapy for a short while. Once you explain to the patients the mechanism by which their spotting is occurring, assuming of course that you've checked for chlamydia and done a pap smear and all that sort of basic stuff, often they're much more accepting and understanding of it and are willing to try the various options.
Terrific. We might take a break there and come back to this.
Olga Ward there with Dr Robyn Leake and Dr Alison Creagh. Now, sometime in the last few weeks, you probably received a resource pack for partner notification for chlamydia. Along with some useful resources for you and your patients, the pack discusses the role and responsibilities of the GP in relation to tracking contacts. To discuss those responsibilities and the implications of the resource pack, we spoke with Dr Terry Patsakis, a GP with a special interest in sexual health.
Terry, welcome to the program.
Thank you.
Terry, GPs have just received a resource kit with lots of information about chlamydia. Are we facing a really big problem here?
Yes, we are in Western Australia. Over the past 5 years, the problem's grown by 50%, which is quite a marked increase. I think we're looking at just under 9,000 new cases in the past 12 months. These cases are mainly in the metropolitan area, though per head of population it's pretty high in the Kimberleys, where it's 1,700 cases per 100,000 of the population. And it's also pretty prevalent in the goldfields and the Pilbara region as well.
Now we've had several sets of information from various sectors of the health
Yes.
department. A letter telling us one thing about screening and this new package, which has quite different information. Could you maybe run us through what's in there and some of the differences?
Well, first of all, they talk about screening, and it doesn't seem to be very practical for general practitioners in a way. We probably have to be opportunistic and screen people as they come in, requesting other things, and then offer them a screening test, especially if you're doing a Pap Nicolau smear or something like that. The guidelines suggest everybody under 25, or who's sexually active, but the statistics are showing that something like, of the 9,000 cases, 27% are in that 15 to 20 age group, 38% are in the 20 to 25 age group, but 18% are still in the 25 to 29 age group. So I'd probably extend these guidelines to 29. They're suggesting screening people under 25 who are sexually active, but the old guidelines, which were only 3 or 4 weeks ago, were saying, and they came out in another document, to most GPs, they were suggesting 29 and under, and that's probably what I would aim at. Then, I can't screen everybody who comes into the clinic if they're coming in specifically for a sexual health check, which is very rare. It's usually at the end of a fairly lengthy consultation. I then sort of try and get them to come back. If they won't, I then do minimal screening.
And Terry, there are quite a few testing options, sort of first stream urines and low vaginal swabs and endocervical swabs, which used to be the gold standard, and urethral swabs. How great is the PCR testing, and how many false negatives are we going to get?
It's pretty good. The only false negatives you're going to get is in the window period, which is, the consensus is 2 weeks. There's no evidence on that, but the consensus is that it's 2 weeks from the time of infection before the result may become positive. So a PCR is pretty accurate, and that will be accurate on a urine test as long as there's a 1 hour period when they haven't passed urine before you take the test. And we're not even sure about that. But a urethral swab's done, but probably not necessary. Also, in a female, you can do an endocervical swab or even a self-collected high vaginal swab, but then again, a urine test will also be fairly accurate. You may miss the odd false negative, but I think that's part of the course.
And if you're doing a Pap smear, of course, it's easy just to do an endocervical swab and get a good specimen.
The guidelines are suggesting pharyngeal swabs, but I've never had much luck with those anyway. I think I've had one positive result in several years, and if they're men who have sex with men, I'd offer them an anal swab if they have a receptive anal intercourse.
So Terry, could you go through the process that you use to inform a patient that they've got a sexually transmitted infection?
Pretty bluntly, I sort of sit them down and talk about their sexual activity, presuming I've already taken a fairly long sexual history in the previous consultation, and then bluntly tell them HIV probably is a bit different, and I hope that they've had pre-test counselling and they're ready for a positive result. But certainly with chlamydia or gonorrhoea, if they're asymptomatic, I'd be pretty blunt with them. Tell them the diagnosis, and then start talking about treatment, and then talk about contact tracing.
Yeah. What's your most useful treatment for chlamydia?
Without a doubt, it's azithromycin, 1 gram stat. I like seeing them take it, but sometimes I have to write a script, or most of the time I have to write a script. They have to go and pick it up and take the medication themselves.
And how do you ensure it's clear? Do you still do test of cure?
Well, these guidelines say no, but if it was somebody I was seeing, I'd hope that they had a negative test of cure before I had a relationship with them. So I leave that up to the patient. I certainly would like to see them in 3 months afterwards to make sure that they either haven't got reinfected or that it's a sort of test of cure. But 3 to 4 weeks after treatment, I'd recommend a test of cure.
Yeah. Now, that kit that you're holding from the health department suggests that they're no longer doing contact tracing. What about the box that we tick on the notification form?
Well, they've got 9,000 cases, so you can see a pile on their desk, which is way high. And
a bit like the pile on the GP's desk.
Well, yes, yeah. And so I think it's gone past the tipping point. The disease is out there. I think their guidelines are, well, we can't do it, you guys do it, but I don't think they realise that our resources aren't any better than theirs. So contact tracing is going to be a difficult proposition. I'd certainly look at a few groups. The under 14s I'd hand over to the Public Health Department as soon as possible. And I think in this resource folder they have the nearest public health people. The under 14s, I really don't have...
That becomes a sexual assault issue as well, doesn't it?
Yeah, and I don't have the ability or the training to really take a history from a 12-year-old about their sexual life. So, I don't feel much more comfortable with handing that on. Similarly with the under 16s, again, I think they probably will be handed over to the Public Health Department. I think they would be looked at fairly carefully. Pregnant women, I wouldn't want them to get reinfected. I'd contact trace them myself or encourage them to make sure that they follow up with their contacts. And the other group are anybody who's got another sexually transmissible infection, so especially HIV or something, because you want to know whether they're having safe sex and whether they could pick up some other diseases or spread HIV.
So if we actually tick the notification box,
yeah,
the health department might actually follow up somebody who was under 16? Or would we have to still write them a note or ring them up?
I would follow that up, but I presume they would follow it up. But then, you know, with a pile of 9,000, who knows whether they're going to get missed. I'd follow that up with either writing over the notification form saying this needs urgent attention or with a phone call to your local public health department.
Yeah. Now, if a GP is called upon to do some contact tracing, how would you go about that?
Well, that's what this document's asking us to do, but if I took the name, say I had 3 cases last week and I took the name of the contacts, that could be anything up to 10 to 12 people. I haven't really got the resources to contact those people, so I would take the practical attitude of encouraging the patient who's got chlamydia to notify their partners. Now, if they're reluctant to do it, then I could offer the ability for them to notify their partners anonymously with a letter. There was a site in this document that they could go to send an email anonymously, but apparently that's been taken off because some kids got onto it and notified a whole lot of other people maliciously, so they've had to take that site off. But there's a card in here too which they can give to their patients, that GPs can give to their patients for the patients then to forward that on to their contacts.
Yeah. Now, in a country town, of course, everybody knows everything about everyone else. How would you ensure confidentiality when you were contact tracing?
As much as I could, really, but people do put 2 and 2 together and they'll know very quickly who their contact is, but there's not much else you can do about that. Yeah. If the patient's given the name of a contact, then, and if you feel like contacting them, then it's going to be known throughout the town probably in some cases.
And finally, Terry, do you have any tips for country GPs dealing with chlamydia cases?
I think just to really try and test opportunistically, look at sexual histories if you can, if you've got time. On most of the younger clients, people are getting sexually active from the age of 15, 16 onwards pretty much throughout Australia. And to encourage the patients to contact trace and then to take the opportunity of offering advice about safe sex.
Great. Thanks for joining us today.
Thank you very much.
Thanks to Dr. Terry Patsakis for letting us come in and disrupt his practice. And if you haven't received the chlamydia resource folder, they're available through a WA Department of Health website at www.couldihaveit.com. Now let's go back to Olga Ward and her discussion with Drs. Robyn Leake and Alison Creagh.
We were talking before the break about contraceptive pills and choosing the right pill for the right woman. Alison, there's a lot of patients who come asking for the pills that are marketed as side effect free and no weight gain. What sort of experience have you had with the various types of pills and the patient's side effects?
Yeah, we've certainly found that, well, I suppose there are two things. One is the woman's perception of the pill, and often if she's requested it, she's a bit happier to take it. So,
yeah.
I think there are perhaps some psychological benefits there. But I do find that sort of sometimes the marketing isn't actually what the woman reports when she comes back. For example, the ones that are said to lower the mood symptoms don't necessarily, and I've certainly had a number of young women have worse mood symptoms on the ones that are marketed for mood.
Okay, now you'll probably have to use brand names here because...
well, the drospirenone containing ones, so there are two different doses of that one. And also occasionally I've had people on the ones that contain cyproterone, the ones that are better for skin. Again, people tend to have more mood symptoms with those. Sometimes it's a bit of a balancing act. They get great skin benefits, but they get worse mood symptoms, and so getting them to choose which is the more important to try and deal with is...
Sometimes I find after their acne's controlled, you can switch them onto something nice and cheap and cheerful with norethistone, and they seem to sit there. That just seems to be less...
Because the oestrogen increases their sex hormone binding globulin levels, which in turn lower their androgens. So any pill will do that. Any oestrogen-containing pill will do that. The cyproterone has slightly more anti-androgenic effects, but like you said, you often don't need the cyproterone. It's the oestrogen and its effects on
once it's
androgens.
done its bit, you can crank it back and keep it there. Robyn, have you had a similar sort of effect
definitely.
with the drospirenone type pills? Yep. And how do you manage changing somebody over between methods of contraception? So they've been on the pill for years and they suddenly decide they want a Mirena, or they suddenly decide that they'd like to go on the depot because they're frightened of oestrogen, or their mum's had breast cancer at 70 or something. Yeah,
it's good, and it often requires you to sort of remember, well, how's it working and how long is it going to take before the next method begins to work, and how long is the method that they've just been using going to continue. But you're pretty safe changing anyone over from just about anything days 1 to 5 of a cycle. So provided there is some sort of cycle, usually if you either change from something immediately or days 1 to 5 of a cycle, you're usually covered.
Yeah. And the depot progesterones, I guess you just wait for the end of your 12 weeks and jump in there, or 11 weeks or
11
something.
weeks is ideal,
And I think it's important if you're changing from a method that suppresses ovulation or ovarian function, such as the pill, to something like a Mirena, to warn the patients that their cyclical symptoms will return: breast tenderness, premenstrual bloating, possibly some mood swings, not to put them off the device, but merely to inform them, so that when those cyclical symptoms return, they don't feel that something terrible's gone wrong, or that it's the device that's at fault. I must say,
or it's dropped out.
A lot of women feel much more normal, if I could use that, off cycle suppression, and so they say, this is what I used to be like. But other women, the return of cyclicity isn't necessarily welcome, and I think it's important when you're counselling them about Mirenas or in fact copper-containing IUDs, to make them aware that the cyclicity will return.
Alison, do people still use natural family planning?
They do. We don't tend to see quite so many people using that who come to FPWA, but there is quite a good centre which does very thoroughly go into natural fertility methods. I'm just trying to think of the name. Natural Fertility Services, it's called, which is in West Perth. Probably not greatly accessible for rural folk, unfortunately. But I think if someone is going to use natural methods and they really don't want to conceive at the moment, they really need a good thorough education. So we can certainly start the education, but it's probably better for them to be followed up by the natural fertility folk, to look at all their charts, make sure they've understood everything, make sure both partners are happy with the method.
I know a lot of the patients think about natural family planning as being taking their temperature every morning, but Robyn, that isn't the case, no?
Well, no, I think there's a lot more to it than that. There's awareness of a lot of other symptoms, examination of the mucus and all of that sort of thing. And of course it falls down for folks who don't have a regular, predictable cycle, alas. which is a bit difficult for those ladies.
Yeah, it is. And that brings us very nicely to the polycystic ovarian patient who doesn't have a regular cycle but who may in fact still manage to achieve a pregnancy quite quickly, much to our surprise. Could you tell us a little bit about how you manage patients with polycystic ovary syndrome and particularly how you talk the patients through it?
Sure. The first thing I make them aware of is that it's not actually a problem with their ovaries, but rather a hormonal imbalance to which their ovaries are responding. The name polycystic ovarian syndrome is a very ancient misnomer probably. And the way I explain it to them is that there's a cycle, in amongst the lack of cycle, but there's a cycle of problems, and that is that the ovary is not ovulating. It often produces excessive amounts of androgens, which create the skin and acne problems from which women often suffer. And the other side effect of excessive androgens is weight gain, and the weight gain tends to be central. That in turn makes higher insulin levels, which feed back to the ovary. The ovary dislikes insulin intensely, and in the presence of excessive amounts of insulin makes more male hormones, and so the cycle continues. And I explain it to patients more basically than that, but that's the gist of it. And I say that our role is to try and break that cycle somewhere in the pattern. And I talk mainly about bringing insulin levels down with regular exercise, appropriate diet, and sometimes the addition of metformin. Thereafter, I focus on what the patient wants. So if the patient would like cycle regularity, we talk about ways of achieving that. If the patient wants conception, we talk specifically about that. If the patient wants control of acne or hirsutism, we focus specifically on that. And often, of course, these requirements overlap. But that's my way of describing it to them.
Yeah. Alison, do you have anything to add to that?
No, we would do the same, really. It's sort of establish whether it appears to be PCOS in the first place. Try and make sure the woman has a clear understanding of what that is and how that can change with time and with weight. Make sure she understands that probably there's a need for regular follow-up, and I usually encourage people to make sure they've got a good GP that they can have that regular follow-up with for checking their cholesterol and blood sugar and all of those ongoing
I know they
things.
often freak out because they think they're going to end up, fat and hairy with no children, but evidently this isn't the case. And I do see quite a number of women with what seems to be well-established PCOS who are in fact skinny and very active.
Yep, that's the lean subgroup, well described, are unfortunately just at risk of hyperinsulinemia and insulin resistance later on. So although they don't have the central adiposity, you do have to measure their insulin, or their sugars, and educate them about their long-term well-being in terms of, like you said, the folks, often the overweight ladies eventually go on to develop syndrome X, if you can call it that, but it's the same kind of continuum, I think.
So we'll be checking those women pretty carefully for gestational diabetes as well when they do eventually achieve a pregnancy.
And when they're postmenopausal, for insulin resistance, hypertension, hypercholesterolemia.
Any problems with, say, a teenager with PCOS using the pill for cycle control?
It's a fabulous idea. It'll bring her testosterone levels down and bring down reduce her androgen and her acne and hirsutism. Give a normality to their cycles, which is psychologically quite important in any age group, but especially that age group. It makes the little cysts on the ovaries disappear often with time. So I think it's a great option.
What about our patients when they eventually do decide that they're going to get pregnant and it doesn't happen? How do you start investigating fertility? From a
Do you want to start?
maybe country GP point of view, Alison?
Yeah. I guess knowing what their cycles are doing, whether the cycles sound like they're regular or they may have something like PCOS. If they've had sort of amenorrhea at times, and whether there might be some contributing factors to that, such as eating disorders or just low weight or excessive exercise, as I've sometimes found. If sort of depends a bit on the age too. If they're getting up to the sort of upper age range, like approaching 35 or beyond, I'd tend to maybe do a few quick investigations and then refer to the specialist in case they're going to need some fertility treatment if they've been trying for 6 months or more. If they're younger, I'm happy, as long as they've only been trying for a while, just to give them a bit of information and see how they go for 6 or 12 months before considering referrals. But if we're doing investigations, I guess make sure they've got their basic antibodies to rubella, varicella. Check perhaps a day 21 or sort of post-ovulation progesterone level to see if they're ovulating at some stage. Make sure their FSH and LH are relatively normal early in the cycle. And estradiol. Because we're on TV, I can't remember what I've said now. And that's probably about it, unless there seems to be a reason to look into other things like TSH or prolactin if they're not having regular cycles.
Would you add anything to that basic investigation list?
Check out the boy.
Yes.
I spend quite a lot of time as a gynaecologist checking out the boys.
Yeah.
I think it's, unfortunately, oligospermia is increasing in our society. I think there's good evidence of that. We don't quite know why, but certainly problems with the semen analysis I think are becoming more common. So I think check out the lad fairly early on would be the other
I
thing.
think if you're going to find a problem with either of them, 50% of the time it's
going to be the bloke. Now, in a country situation, that still needs to be a fresh sample so that they can tell whether the sperms have got two heads and a swimmer. So that would obviously need coordinating with your local lab so that somebody can actually look at it.
Absolutely, yep.
Sounds like that's going to create enough problems. Now, what about all these women who come to see us who are 40 and who've decided that now is the time? They've paid off their house and now they want the child for the nursery. Robyn, you probably end up with more of those than Alison and I do.
Yeah, I think basically go through all the things that Alison's mentioned. A day 2 LH, FSH and estradiol. I usually throw in the TSH and prolactin at that time as well. Often they have an idea whether they're cycling regularly or not. If they are, then I do a day 21 or thereabouts progesterone, depending on the cycle length. The question of when to start investigating is always fraught at that age. Often by the time they come in, they've already been trying for a while, but if they haven't, I think it's a bit hard to justify jumping in straight away with investigations. I'd do, as you've said, the prenatal bloods, inform them about the importance of folate and iodine, not smoking, and wish them all the best, but give them the advice that if they haven't conceived, probably within 6 months to let us know. It's difficult, It's hard to say at that early stage that you should be doing too much investigating, but by the same token, you don't win any points for waiting till they're 42. No, exactly.
And balancing that sort of the information that, well, it tends to take a lot longer when you're 40 than it does when you're 20,
Indeed.
but also not, well, it tends to take a while, so don't worry too much, but also, come in if you're not getting pregnant because you might be running out of time. So balancing that information I always find quite difficult.
Trying to access assisted conception services in country areas is quite difficult.
Very difficult.
Is there anything available in regional centres or is it all Perth-based?
Certainly there's, Bunbury has an involvement. The basic investigations such as laparoscopies and whatnot can be done in some of the regional centres, of course, but I don't think there's any IVF, for example, in the rural areas.
Now, speaking of those older women who are having trouble getting pregnant, they will eventually hit the menopause. So who's got the miracle cure for hot flushes?
Do you want to start?
Definitely silence here.
Miracle.
With hot flushes, I try to obviously establish how severe and how debilitating they are. The things, often it's not hot flushes alone that upset patients. It's sleep disruption, poor concentration, and it's rarely just flushes alone that are the problem. General well-being is actually important. So regular exercise is one of the most potent things that women can do to help keep their flushes at bay. Not at the time when they're exercising, they'll flush more, but thereafter they should flush less. Keeping a healthy weight range and a healthy diet, all of those things are actually quite important, and it's important to reinforce those. In terms of the symptomatic control of flushes, I don't think there's any doubt that nothing works as well as oestrogen does, but not everyone is wanting to go down that route. So in a patient who's in whom oestrogen is contraindicated or relatively contraindicated, there are other agents that can be used. Clonidine is an oldie and fell out of favour as HRT fell into favour, but it's being re-examined as an option, and works well for some women. The SSRIs have been studied and are useful in probably 50% or more of patients.
Are you looking at a really low dose then?
Yeah, venlafaxine has been probably studied the most, but there's some evidence that the other SSRIs work as well. And the other agent that's gaining some popularity for the control of hot flushes is gabapentin. It's limited, of course, by its expense and some of its side effects, but it's also been studied and found to be useful.
And for the patients who can take hormone replacement, it was very in and then very out, and it seems to be coming back into favour.
Yep.
How safe is it?
It again depends on the individual, of course. For most women, though, it is pretty safe, to be honest. The data suggests that if you commence someone on hormone replacement therapy at the time of the perimenopause or very early into the menopause, who has no other cardiovascular risk factors of which we've spoken in reference to the pill, then the cardiovascular risks for that woman are very low indeed, especially with low doses and short-term usage. Some of the more frightening data is related to women who've been not exposed to oestrogen for a while and then it's reintroduced. And that's a different scenario entirely. As we mentioned before, the risk of thromboembolic phenomena increases as we age, and that's an unavoidable fact of life. So re-exploring the other risks for thromboembolic phenomena are important. The breast cancer issue, the increased risk of breast cancer on oestrogen-only replacement therapy is minimal. It's the combined therapy that has the slight but real increased risk. And I counsel the patients that it's a real risk, but it is actually quite small. You have to balance that against the fact that unfortunately in our community breast cancer is relatively common.
Yeah.
And we talk about surveillance, regular mammographic surveillance, and again, using the lowest possible dose for the shortest duration of time that's practicable.
Alison,
there are some benefits as well. So usually when I'm talking about, you've got a small increased risk of, say, thrombosis and stroke if you start at menopause. You've also got a reduced risk of osteoporosis and bowel cancer if you take combined hormone therapy. And then there's that increasing risk of breast cancer the longer you take it. So I usually sort of make sure they have that bit of balance.
Alison, do you have older patients who are still taking hormone replacement and absolutely can't get off it?
I have, yes.
How do you talk them through it?
I suppose just sort of revisiting what we know this year as opposed to last year when I gave you the last prescription, and considering whether it may be time that they could either reduce their dose at all, or if they're really absolutely unwilling to do that and they haven't developed any extra risk factors for cardiovascular disease or anything, breast cancer, then I'm usually quite happy to, once they've had a good chance to have a think about it again. One
keep
patient,
them going and keep trying to wean it off.
Yeah. But, I think if it was me and I got hot flushes every time I tried to wean down my hormone therapy, I'd probably stay on it as well. Yeah.
I find one of the commonest reasons in my patient group for patients wanting to commence it or continue it is, women who used to being well in control of their lives, professionals, active, thinking a lot, finding that their brain has gone AWOL. They just can't stand that. They say, it's not me. I used to be able to organise myself, think clearly, and it's the cognitive dysfunction that patients really, really resent. And I can understand that. They want to be able to function, they want to be able to sleep, and to not flush, and I can understand that entirely. I think it's very, very reasonable.
Well, thank you very much, both of you, for joining us today.
It's a pleasure. Thank you.
A big thank you to both Dr Robyn Leake and Dr Alison Creagh for making themselves available to us, and I hope you found that discussion helpful. Well, our final segment tonight looks at mental health in pregnancy. While people seem to be better aware of pre- and postnatal depression, there are a range of other mental health problems that can be associated with or exacerbated by pregnancy. To find out more about mental health and pregnancy, we visited the WA Perinatal Mental Health Unit at King Edward's.
The WA Perinatal Mental Health Unit, we are what I call the behind the scenes of perinatal mental health in WA.
It's a non-clinical unit, so it's involved in coordination of services, service expansion, development of health promotion, education and training for health professionals on issues surrounding the perinatal period, and most importantly it's research based as well, so underpinning everything is research.
If you're needing clinical support, I'd recommend contacting the mother-baby unit for triage support, or contacting King Edward Hospital. But if you're wanting information on what resources are available or education and training, then we are definitely the people to contact for that. We've got a lot of information about becoming a parent and the emotional experience of becoming a parent, and acknowledging for women that, and dads too, that it's not necessarily all easy sailing. That there's a variety of emotions that people do experience during that time. So we have a specific website dedicated just to health professionals to provide them information and resources. We've also got on that website for health professionals all of the resources that are available to order from our unit. And some of those resources are just for health professionals. And some of those resources are sort of to hand out to consumers as well. There's some extra tip sheets and fact sheets which are only available online, which people might find useful. A lot of anxiety disorder tip sheets, the different sorts of anxiety disorders, including phobias, specific phobias like fear of childbirth and fear of needles and blood and things like that, which are very difficult issues to have when you're about to have a baby. So there's some specific tip sheets on that, and a whole range of other information for consumers as well.
By raising awareness, we hope that people who are seeing women in the perinatal period are identifying mental health issues much earlier, so interventions can be applied much earlier, and then we hope that the impact of the mental health problems in the perinatal period are less severe.
The idea of postnatal depression is well and truly out there in the community, and a lot of health professionals are certainly very well aware of that issue now. What isn't so ingrained in the conscious of the public and health professionals is issues like antenatal depression. And the important thing with antenatal depression too is that it can continue postnatally, and it can become worse as well. So the antenatal period is actually a really important time for intervention, for early intervention, so that you know, those problems don't get much worse, aren't exacerbated, because they're so much harder to deal with once that baby does come along. Another issue that is really important, and I think is on the increase in terms of awareness, is anxiety issues, both antenatally and postnatally. So we're starting to see that they actually might be more common, more prevalent than issues of depression, and sometimes they can coexist with depression as well.
Anxiety is quite common. Lots of people will experience anxiety, but we're talking about problematic anxiety when it starts impacting on somebody's life. So they don't want to go out, they don't take the baby to appointments, they don't go to play groups because they're too anxious to leave the house. Women with anxiety tend to read a lot of the literature and think, no, that's not me, I'm not depressed, but they're also not settled.
They're not feeling like they would normally feel. They don't feel like themselves, and they're in this state of being completely stressed and so highly strung and worried all the time and not being able to sleep. But they don't identify with that label of depression, because it's just not them. They're saying, well, I'm enjoying my baby, and it's not depression that I feel, I can't relax, and I'm panicked all the time, and I'm just so stressed, and that's probably more likely for those women that they actually have an anxiety issue. So it's really important for GPs to be aware that that might be an issue for some women.
I think probably the biggest risk for perinatal mental health problems is a previous history of depression or mental health problems. So probably one of the first things I would talk to a woman about was her past history. Had she ever suffered from perinatal, had she ever suffered from a previous depression. I would talk to the woman about what her pregnancy was like, what her delivery was like, did it match her expectations, was it a traumatic delivery? And it's not really what we think the delivery was like, it was how the woman perceived it. So even though the delivery may have been successful, the woman might have perceived of having no control or losing control of her body, and it may have been traumatic for her. I would talk to women about what sort of practical supports they have, what sort of family they have around them, what their relationship is like, what they did previously. They might be quite isolated if they're used to being a professional person who went out and worked every day. Any problems with the baby? If you have an unwell baby, you've got more likely to feel stressed. Be teasing out sort of things like what type of a person they were. Did they tend to worry a lot? Were they guilt prone? Were they perfectionistic? Did they like everything to go a certain way? And we know that there's a personality type that is more likely to be at risk because of the internal desire to have everything perfect.
A fantastic resource that we have for all health professionals is this EPDS translated versions file, which has, I think, 36 different translations of the Edinburgh Postnatal Depression Scale. It's 100% free for anyone working in Western Australia. And if GPs are interested in having copies of the Edinburgh Postnatal Depression Scale in English readily available, we have heaps and heaps and heaps of these available to order. Again, they're a free resource, and we can email them out again in PDF so that people have them sitting on their desktop ready just to print out and use with women. A brand new tool that we have for health professionals at the moment is the Edinburgh Postnatal Depression Scale Wheel. So say a woman comes in, they do the EPDS, they get a score of 11, you just turn the wheel around, go, okay, that's 11, so what risk are they? It's moderate risk, and that gives you some hints and tips about what you might like to do with that woman. A lot of people are familiar with a booklet. It used to be called the Yellow Booklet for short, but it was the Becoming a Parent booklet. It's recently been revised and given a whole new look. It's been given a makeover, and one of the aspects of redoing this booklet that we found was that women are actually wanting this resource antenatally, not postnatally, and GPs were actually identified by women themselves. When I spoke to them during some focus groups, they said GPs, should be giving out this resource. So if you come across a woman in who's pregnant, having a baby, probably around the 20 to 24 week mark, I'd recommend handing out this booklet. If you want copies of this booklet to hand out, just contact the Perinatal Mental Health Unit. Mothers are really, really good at putting on the mask and everything's okay, and yes, I'm the perfect mother and everything's going fine at home. And sometimes the EPDS can often be a really good way to tap into a woman who might be pretending that everything's okay when it's actually not.
We want them to be very aware when seeing women during the perinatal period, just to be very aware of mental health issues that can occur, just so that women are kept well informed, women feel that there's an open door policy, that they can get information, they can talk about how they're feeling, and that there is support available.
So I guess the take-home message at the end of the day, if you're wanting resources to deal with women in the perinatal period, either for yourself as a practitioner or for the consumer, if you're wanting consumer resources, or information about education and training, do contact the Perinatal Mental Health Unit, because we've got a lot of information that we would like to share and a lot of training that is available.
And a big thank you to everyone at the WA Perinatal Mental Health Unit for that information. Well, that's all we have time for in this broadcast. Don't forget that if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. And please don't forget to send in your evaluation forms so you can receive your CPD points. We're back again in February of next year with a program on dermatology. Thanks for being part of our programs in 2009, and we're looking forward to bringing you another series of broadcasts throughout 2010. From all of us here, good night.